I would now like to introduce our next speaker, Dr. Sally Meade. Dr. Sally Meade was raised in Charters Towers and graduated from the University of Queensland in 1993. Dr. Meade went on and completed a Royal Australasian College of Surgeons Fellowship in 2002 and obtained a postgraduate fellowship in the specialty of breast and endocrine surgery. She's a member of several professional organisations such as Breast Surgeon Society of Australia and New Zealand, Australian and New Zealand Endocrine and International Association of Endocrine Surgeons. As a breast and endocrine specialist, Dr. Meade joined North Queensland Minimally Invasive Surgery in January 2005, and she has worked across private and public hospital surgical practice in Townsville since 2005, and also is a senior lecturer in surgery at JCU. Over to you, Dr. Sally.
Thank you so much for inviting me. I'm just going to share my screen with you, so I may do my PowerPoint presentation. Is that working okay for everyone?
Yeah, we can see that, Sally.
Okay, excellent. Well, we'll get going because we're going to talk a little bit today about breast screening. Firstly, though, why would we screen for this disease? Well, breast cancer is the most common cancer diagnosed in Australian women. 1 in 8 women will be diagnosed with breast cancer in their lifetime, and 7 women will die from breast cancer every day in Australia. Don't forget, men also can develop breast cancer, and about 1% of my patients and patients in general are breast cancer patients are male patients. Overall, the breast cancer incidence is increasing, and I think that's for many reasons. Estrogen exposures, significant contribution by lifestyle choices that we make in our Western society, but it's very significant increasing disease. But happily, though, survival is also increasing quite significantly. In significant part, I think, to improve treatments, but a very important part of it is also around early detection. So early detection is key for improved survival in women, and prevention ultimately would be our aim. So knowing that Australia has a screening program, it's one of 3 major population-based cancer screening programs, along with colorectal and cervical screening. This is a joint Australian and state territory initiative, which was first established in 1991. And its target is for women aged 50 to 74. These are people we actively pursue by sending out an invitation to come, and they're for 2 yearly screening mammograms. So that's what they are, and these are for asymptomatic women. I'll talk on that a little later. So women from 40 to 49 are eligible to attend. They can rock up, but they're not actively pursued. And similarly, those women over 75. And another point, I do see a number of 75-year-olds or older patients who've sort of been told that they can't screen and they shouldn't screen as they get into old age. But actually, age is the biggest risk factor, really. And I think as women remain well and fit for care, it is much easier to deal with an early cancer than for these women particularly to turn up with the locally advanced breast cancer. Although, of course, their comorbidities also must dictate what we do to them. It's clearly we're not going to be sending along somebody for screening if they have their dementia in the nursing home. So, and that comes down a lot to GP communication with patients and what's appropriate for treatment of them. But still, I think if someone's really fit and well and we anticipate them living for another 20 years, they should keep screening. So the benefits of screening, as we just said, improvements in survival. So this is really significant. In those screening participants, the mortality is reduced by up to 50%. and which brings overall our population level breast cancer mortality is improved by 21%. Oh, it's reduced by 21%. But not only with the mortality, the impact, this is a very common disease, and women are surviving it. So what we do to them with our treatments, they have to live with then for the rest of our life. So if we can do less treatment, which means less surgery, more breast conservation, less auxiliary treatment, and likely lymphedema that everyone goes on about and fears, and the requirements for less toxic systemic treatments can only be a good thing. So fabulous screening, yay, we should all screen. So how are we going with screening? Despite the known benefits of it, overall Australia-wide, the participation rates really, outside of the initial years of screening where they were reasonably high, they've really hovered around the 50% mark. But Breastscreen Queensland, yay, we're doing really well compared to the rest of the state and the nation. And I think that's because we have a superior team here in Townsville Breast Screen Service, and very actively engaging with general practice, with our regional rural locations, through articles and advertising, and also active planning with our Aboriginal and Torres Strait Islander workers, scheduling even group days out, lovely days out to a beautiful new facility out at the Domain. Accessibility, though, still remains a problem for a number of people across the community, rural and remote, Indigenous, linguistically challenged people, and those from lower socioeconomic groups. So these are things that we do need to continue to strive to find solutions to improve accessibility for patients to screen because of the benefits. I saw Greet spoke a little bit about the impact of COVID on screening for cervical cancer, but this is what's happened in breast cancer. So in April alone this year, normally, so standard screening in April as compared to 2018 was about 74,000 people that month. So in April of this year, across Australia, we screened 1,000 people. So that's a really stunning reduction in numbers. So the numbers from January to June, there was 145,000 fewer screening mammograms this year compared to the same period in 2018. So on average, we might say diagnose about 5 people out of every 1,000 screened. So that'd be over 700 missed cancers from screening. So I don't know where all those people currently are, but they will no doubt present in due course. But we just are not sure of the impact of that at this point. So while screening, though, is great to pick up these things, there can actually be genuine harms of breast screening. So this is the challenge for the screening programs, and there's been some, really emerging international literature. These great articles that I've listed here, the Marmot report from the UK, and then the systematic review from the prevention forces in America, looking at the problems of screening. And so let's just look at what happens to somebody when they come into screening. So for every 1,000 women who have a breast screening mammogram, 100 of them will be recalled for additional mammograms or ultrasounds because there's been something seen by the readers. And out of that 1,000 patients, 61 will have additional imaging and find nothing is wrong. So those people have had a lot of anxiety and distress over that diagnosis, and women go along happily thinking they've had their screening, and they get their recall, and suddenly this is a possible reality for them, and it's a significant source of stress and anxiety of going forward. 20 out of the 1,000, what was seen on the imaging is likely not cancer, but they'll have to come again in 6 months to just sort of keep watching and looking at it. 19 out of that 1,000 will have a biopsy, and 5 of which will be diagnosed with breast cancer. So that's another 14 women who've had a biopsy. So the pain and discomfort related to that. And so a significant number then out of these of false positive results, so calling back and it doesn't turn out to be a cancer, and the distress that goes on with that. There's a significant amount of radiation exposure as well associated with mammographic screening, and obviously the cost of all of this additional testing. The other hot topic as well around harms of breast screening is this concept of overdiagnosis. So diagnosing a cancer, a small cancer or a precancerous lesion like DCIS, which is cancer, I guess, but non-invasive cancer, that may never result in any adverse outcome for the patient over time. It's not going to kill the patient. You know, they would live and die with this lesion. Those patients at this current time is very difficult to weed out. We've found this cancer, then I don't think there's anyone that can really let this go and leave it alone, because we don't really have enough knowledge about what really happens to these cancers in the natural history. So these women we can't weed out the ones we are actually overdiagnosing, so they all receive treatment and the potential treatment-related toxicity. So something to really consider when we're counselling our patients around going and having screening. And Breast Screen has these, they're not really waivers, but when patients turn up to participate, they talk about this is what happens to you with the screening. So that all being said, the challenge moving forward with screening for all screening types, but particularly for breast, which I can only speak on breast really, is this concept of personalised risk-based screening. Screening, fabulous benefits, but equally there's significant harms. We're going to overcall a lot of things in women. We're going to undercall in some women. Breast screening by mammography at 2 yearly intervals is actually going to let some women down grossly. Doing that in some women is a real screening, over diagnosis, over treatment of women. And so how can we be better to screen the people that really need to be screened and back off with our intervals and our modalities of imaging on patients who really don't need it? So I'll draw your attention to this really useful tool looking at identifying risk of patients. This is a Peter Mac initiative. So you just go into this iPrevent web page, and it will just come up with there's a section for health professionals. Actually, you can go in and read all about the tool and what it all means for people. And then with the recommendations, including risk reducing medication and so on, all the side effects and indications and so on. But you can go in and log in all of the patient's details, age and family history and cancer history and personal history and so on, and come up with a risk to try and then have a conversation around appropriateness of screening for patients, because this just 2 yearly screening I think is just really starting to be outdated. We are going to have to incorporate more genomics, genetic assessment, breast density into our strategy, because one size does certainly not fit all. So what are the risks then of breast cancer? As general practitioners, I mean, certainly this is what I sit all day in my office and think about risk. Women are coming to me because they've either had a diagnosis, because they've got a symptom, but a large number of my patients really want to know about their risk and how I'm going to recommend going forward with their surveillance or risk reduction strategies, such as surgery or medications. So this is what I go through. What are the risk factors? So looking here, how might these also impact on what my recommendations are around screening? So a patient has had a history of chest wall radiation, say mantle radiation for lymphoma, major occupational exposures or head and neck cancer treatments. significant risk of developing malignancy. These people are as high as the BRCA1 gene mutation carriers in terms of getting breast cancer. And so they need to be screened in a different way. History of breast cancer. And again, the personal history we'll talk about a little bit later around risk stratification based on family history. But history is important to take as well to try and see where this patient might be. Everyone seems to be able to dig out a relative with breast cancer, but then there's breast cancer families and there's breast cancer families. Extremely dense breast. Breast density is something that's just, you know, underrated and underappreciated in terms of challenges for screening and risk of breast cancer. We can see here the relative risk is 4.5 for breast density, so significant factor in independent risk factor in development of breast cancer. Past histories of benign breast disease, but that with the atypia and particularly lobular type histologies can increase our risk of breast cancer. Relatives, and then all of the hormone sort of exposure risks. Obesity. I think, you know, this is one of the things that we're seeing in breast, particularly the lifestyle choices people are making. Now, people come to me, they're morbidly obese, they drink, you know, a bottle of wine every day, they smoke cigarettes, and they're terribly concerned that they have developed breast cancer. And you were thinking, well, why wouldn't you develop breast cancer? You know, these behaviours are killing our patients on so many levels. We should be a well population, but our lifestyles are really, you know, negatively impacting in a way. So, you know, particularly in postmenopause, obesity is really important. And as we said, alcohol use, hormone therapy, so HRT. I get asked a little bit about the use of this. Of course, estrogen is the font of youth, healthy bones, healthy heart, general well-being, sleeping well, feeling well, looking fabulous. And so, of course, we all want that. And but if people are postmenopausal and having crippling symptoms, then yes, estrogen is a good thing to do for quality of life, but use of it judiciously, as it is a risk factor for breast cancer, I'm sure you all know. So I'm having to put all those things together to try and determine what's the best way forward for screening, what are the intervals, what are the modalities I might use. So this is about breast density. Why does it matter? These breasts that come in to my office, which are complete whiteout, impossible to see anything in mammographically. Apart from microcalcifications, one could see that. You can see gross distortions, but basically very limited sensitivity in the very dense breasts and a significant relative increased risk of breast cancer. And and this is something that nobody knows when people go off to our breast screening mammograms. As a GP, you never get to know what your patient's mammograms look like. It's not commented on, it's not talked about, and this is something that really we're trying to get introduced into the natural reporting in breast screen, and so people are aware of what their breast density is. It's impossible to get the films from you. You'd never get to see them normally yourself. I get to call them down to me all the time to Queensland X-ray when they've had their screening, because I want to look at them when I'm coming up to surgery. But it's not really an easy task to get hold of those films and look at them if you're wanting to know about breast density. So sometimes if you're suspecting this is a patient with high breast density, it might even be worthwhile doing their initial mammograms privately to get a bit of a look at their breasts and say, well, actually, you know, by all means, yes, if you do nothing else, go to breast screen every 2 years and have your 2D mammography, but might you not be better off having additional adjunctive treatments, screening modalities such as an ultrasound in addition to your mammogram, and sometimes even an MRI scan for those patients. But understanding that dense breast and then the patients being aware of it, because they're blissfully unaware of this, and something I think GPs can help to explain to patients, because it does matter. And I have a number of these women that I follow, you know, over the years, and they get breast cancer. It's quite extraordinary, actually, watching it unfold. Of course, genetics is a really very important part of what we do as breast surgeons now, getting involved in understanding people's risk because of their inheritance of gene mutations. And another website that I would draw everyone's attention to, which is a fantastic website, is the New South Wales government have this EVQ one. You may or may not know it, but if you go to the homepage and look at cancer genetics, and there's a drop-down box going into adult, whatever medicine you want to do, but I look at adults. And they look at gene testing, and then there's a risk management section, and it'll list down all the known sort of gene mutations and syndromes and things, and you can click on, and it gives this fabulous outline of what people's risk are compared to the general population, what other malignancies might be associated with this type of gene mutation, and what is the evidence for screening or risk reduction in those populations. And so that's just a brilliant web page that's freely available. You can go and have a look at it, and just really helps with the counselling and understanding, and gives all the current evidence as well for that. So determining those levels of risk is really important. So, and this is for our moving towards a more risk stratified approach to screening for patients. And I think it comes down to all of us who manage patients from general practice and breast specialists to be aware of this and be able to take a really good history. So most people actually are at average risk. So 95% of the population really don't have much of a risk at all. And so of this group, 9 out of 10 women actually won't go on to develop breast cancer. So these are people with no family history, maybe an older relative with breast cancer, maybe a secondary relative. As I said, we can always find someone out who has breast cancer. And so, these ones, I think, so long as they don't have other risk factors like the radiation or dense breasts, then excellently they can go off and have their screening mammograms every 2 years from the age of 40. Then we move on to the more moderate increased risk patients. And this covers, significantly less amount of the population. And up to the age of 75, they've got a risk of between 1 in 8 and 1 in 4 chance of getting breast cancer. And these are ones who might have one primary relative diagnosed at a young age, or 2 primary first-degree relatives on the same side of the family diagnosed with breast cancer, or 2 relatives on the same side diagnosed with breast cancers, at least one before the age of 50. So these ones have a moderate risk, and I would tend to think more along the lines of annual mammograms for these women. Again, taking into account breast density, is mammography alone the best screening tool for this person? Should we use, in addition, say, ultrasound scanning for those women with gross fibrocystic change, clinically and radiologically difficult breasts? I think it's worthwhile using additional modalities for that group of people. And then, of course, we move into the potentially high-risk group. So identifying these patients and referring them off so they can have a good discussion around what is the screening, risk reduction, and potential for genetic testing. So these women who have, 2 or more first or second degree relatives on the same side. This is the same side. So I keep getting referrals of people who've got one here and one there. And so we can't add up the sides of the family and make that 2 relatives. So obviously it's coming down the same gene line. And those that might have additional cancers such as breast and ovarian cancer, or cancers at a young age, bilateral breast cancer, Jewish ancestry, cancer in a male relative, these should all really start ringing alarm bells for thinking about sending patients off for discussion around their risk. Addition of sarcoma, and obviously if someone has a high risk gene mutation, then if there's a known family gene, then that person can actually be referred to genetics for gene testing. well, gene counselling initially, because there are implications for having testing around life insurance and so on. So it is important to allow people to get access to that. But so this is on the Cancer Australia website, looking at risk stratification and the ongoing surveillance for these potentially high-risk women. So these are, again, for asymptomatic women under the age of 50. They're eligible to have breast MRI scan. I alternate breast MRI with 3D mammography plus breast ultrasound 6 monthly, and so they're having each modality annually, but they're having something 6 monthly. These women will turn up very quickly at short intervals with breast cancer. So that's what we would do for screening for those women. We talk about risk-reducing medication with SERMs, such as selective estrogen receptor modulators like tamoxifen. And we also may talk about risk reduction surgery in these women. Harder to talk about having risk reducing surgery in the absence of a gene, a known gene mutation that we can identify. If there is a gene mutation in the family, the woman will have a 1 in 2 chance of inheriting it from an affected member. And so if we actually can't identify the faulty gene in this family, and we really only can identify a handful of known genes, but there are families out there who obviously have some sort of gene mutation. We just don't know what it is yet. So for them, it's really difficult because we can't say yes or no, you don't have the gene mutation. Word on gene testing an unaffected family member. So often patients will come along and want to have gene testing when they've never had breast cancer. Tricky thing to do, we would preferentially test an affected family member to see if we can find a family gene, because if we can't find a gene mutation, then there's nothing to test anyone else for. If we can, then we can test anyone else against that single gene mutation. If they have it, they're back at average risk. On the other hand, if we test an unaffected family member and they come back negative, we don't really know what to make of that. That could mean that they haven't inherited the family gene, or it could mean they have inherited the family gene, but even if they did, we don't know what it is, so we can't tell what it is. So it doesn't put them out of the woods of potentially high risk. Also, we can see some unclassified variants of some of the known gene mutations. We don't really know if it is anything, and so then we're labelling this patient with a gene mutation and perhaps sending them off for surgery when they don't even have it. So we don't even have a high-risk gene particularly. It's just some weird variant that isn't pathologic. So there are challenges about testing an unaffected person. Sometimes we will if every single member of the family has died from breast cancer and there's nobody that we can screen or test, but for women who have someone alive, we would encourage them to get tested. Also, another fascination for me is the number of families that don't get on and don't want to talk to each other and can't get the other person to go and seek testing. It's fascinating, isn't it, in medicine and patients that we serve, and they're really interesting. So just as just a little bit of summary of the screening after all those discussions, this is really around the summary of screening based on risk, which is more familial risk than anything. I also would be factoring in, breast density, other risk factors such as past lobular biopsies, past proliferative breast changes and so on. But this is for the populations around familial risk. So the average risk people, no screening before 40, second yearly mammograms through breast screen or wherever, up until the age of 50, then greater than 50 to 74 second yearly mammograms, and until they're not well enough to be screened. Our moderate risk patients, so we don't promote screening for young women over 40. They're eligible to go along and have annual mammography, and in the high risk population, we generally don't start screening before mid-20s. It's pretty uncommon to develop any cancers with the known gene mutations. Probably the TEP53 will start hard and start early. but BRCA gene mutations, rarely under 30 do we see the cancers come along. But we'd be happy to screen from the mid-20s. And up until the age of 50, there's eligibility under Medicare for MRI scan annually. As I said, I alternate 3D mammography plus breast ultrasound with MRI so that they're having something pretty regularly. And over 50, there's no longer eligibility for MRI scanning, but some women will choose to keep having it in the private sector and pay for it through the public sector. I guess as surgeons there, we determine whether that's going to be a useful tool, again, depending on their level of breast density and challenges with screening in general. I would prefer in this group 3D mammography over 2D mammography that's done at breast screening. Oh, a word on screening. If one is doing these tests where we're looking at combining an ultrasound or adding ultrasound or MRI to the mammogram, then I would promote doing that in the one centre. These are complementary tests. So going along and having a mammogram somewhere and then having the other thing somewhere else is very difficult for radiologists to sort of compare. So it's important for radiologists to have access to all of the information. I spend so much of my time tracking down films so that I can find them from all different radiology providers all around the country, actually, to try and look at films, because I don't care about reports. I just look at the films and then just read the reports after that. But it's really important that they are done. They're complementary tests. They should all be done in the same centre. Just an update on Medicare eligibility for MRI scanning. So it does need to be arranged by a breast specialist, but just for you to be aware of patients that would be benefiting having an MRI scan. So these are these potential high-risk patients who have taken the history of high family history, additional, breast cancer and cancers like ovarian cancer, sarcoma, etc. Under the age of 50, they're eligible for MRI scanning. But there are some new eligibility criteria that came out in about October last year that is so great for breast surgeons, because really in these high-risk populations we're picking up a lot of cancers and additional cancers on patients who already have breast cancer diagnoses, and patients who are symptomatic where the conventional imaging is negative. Then we're picking up significant numbers of cancers there. And so as a breast specialist, it's excellent to have this adjunct of the MRI scan. So there is eligibility there for patients who clinically I have a concern, but mammogram, ultrasound are negative. They now have eligibility for MRI scan. Patients with diagnosed cancers where there's discordance between the cancer size, or we're concerned about contralateral malignancy in the case of lobular cancers, then we have eligibility there for MRI scanning, which is fantastic, actually. A little just going along the increased eligibilities for in breast cancer. We also have PET scanning for the stage 3 breast cancers as well. So just if anyone's thinking about staging, when patients have a diagnosis of cancer, then sometimes, or breast cancer, sometimes GPs will arrange for the staging of the patient already. So it might just be worthwhile checking that the specialist might want that to be done, because a PET scan can be superior to a CT bone scan. And certainly there's now eligibility for breast for stage 3 cancers, or patients who have suspected metastatic disease from their breast cancer. And so then they just have to have more radiation if we then want to go and do a PET scan when they've already had the other one. So sometimes it's worthwhile just checking whether that's necessary to be done initially, or whether we just want to see the patient beforehand, because I would have to organise the PET scan. So that's around screening women. Just a little reminder though, we've just been talking about screening. So symptomatic patients, as you all know, really, it's triple assessment. So if someone has a symptom, don't send them along to breast screen to have their screening mammogram. they need to be worked up properly with, proper history and examination, and an appropriate, age-appropriate screening or imaging, which would include ultrasound initially in a young patient, plus or minus mammograms. We can still do mammograms in young women where the ultrasound findings aren't explaining the symptomatology. And of course, for older women over 35, then 3D mammography plus ultrasound. And then GPs typically wouldn't order an MRI scan, but I would order an MRI scan if I felt that was necessary, because there's an eligibility for that. And then some form of pathology, be it core biopsy, preferably, or a fine needle, and a surgical biopsy potentially. So symptomatic patients, they go down a different pathway from the screening we've just discussed. And this is also, just for anyone's interest, has just come out on the web this month. This is new guidance for breast cancer from the Australian government. So it's got all of, you can download the guidance. It's pages and pages of recommendations. But it's actually really very good document going through the treatment and follow-up, and particularly survivorship for patients with early breast cancer. So I think it's really trying to put together all the current evidence and what's best practice. So I think we do have a pretty robust screening program. I think we're going to feel the effects of COVID on our missed screen population. It has made inroads into survivorship of cancer, but we've got a ways to go. Really, I think we need to move now to a more sophisticated risk stratified approach to screening. But the challenge is, how do we incorporate that into screening when we're really only getting like 50% participation rate in the screening program we have? So I believe we need to, as the breast community, really work with all the stakeholders and particularly general practitioners and patients to start understanding and making a screening program that is personalised for patients and appropriate, so that we may avoid the harms and the costs and the cost effectiveness challenges, and really just bring benefits to our patients. So that's all I had to say.